Hello, my name is Vibha Sabharwal. I'm a urologist practicing out of Bolingbrook. I've been in practice for about 22 years now. Just a little background on me. I grew up in the Chicago suburbs for the 4 years of high school that we had, but our family moved around quite a bit before that. I went on to Penn State University after graduating and finished my undergraduate in pre-medicine, which very few people actually choose a major in pre-medicine, but I kind of knew what I wanted to do early on. Then I went to University of Illinois in Chicago for medical school and then stayed there to do my residency in urology. Since then, we've moved around a little bit, but I've been at Bolingbrook for the past 13 years. I wanted to take the time today to talk about incontinence. It's a very common problem, affects 1 out of 3 individuals, and I figured it's something worthwhile discussing. We're going to start with the different types of incontinence. When someone says they leak urine, that's usually not enough information to figure out what's going on. So there's urge incontinence. That's the involuntary loss of urine when you have the urge to go to the bathroom. Remember, the key word in all of this incontinence talk is involuntary. Then there's stress incontinence. That's the involuntary loss of urine when you laugh, chomp, sneeze, any kind of physical stress to the body that causes leakage. The majority of people tend to have both. So they probably have a component of urge incontinence and a component of stress incontinence, and that's what we call mixed incontinence. And then there's a subcategory of people that have involuntary loss of urine because it's overflowing. It could be overflowing due to an enlarged prostate. It could be overflowing due to what's called a neurogenic bladder, which means a person can't feel that their bladder is so full. Happens in diabetics and other people with neurological problems or neuropathy in the bladder, and then they're constantly leaking urine as a result of that. We're going to start with talking about stress incontinence. That's the main focus of the discussion today. Physical activity such as coughing, sneezing, laughing usually does not lead you to leak urine. But as your muscles get weaker, this is the urethral musculature, the pelvic floor muscles that support your urethra. As they get weaker, you can have some leakage. The weakness can occur because you have a family history of incontinence, your mom had it, you're more likely to get it. It can happen due to surgery. For instance, in men that had prostate surgery can develop stress incontinence. It can happen from childbirth. Those kids are the gift that keeps giving. It can also happen if you had previous surgeries, a hysterectomy or any kind of pelvic floor surgery in the past, difficult childbirth. All of it can lead to stress incontinence. And what stress incontinence basically you'll notice is that when I jump up and down or I go running, I can't exercise, I can't laugh real hard without having to cross my legs, or I have to go change my underwear, or I have to wear a pad or a liner as a result of that. It's very common. It affects 1 in 3 women. Generally in men, it's more common after some kind of prostate surgery like we talked about. The men have a longer urethra, so they're less likely to have incontinence, and then furthermore, their prostate provides an extra little support that women don't have, so they're less likely to develop incontinence unless something happens to their prostate. The reason why we're having this discussion is that stress incontinence can have a very negative impact in a person's life. It limits where you go. If you go to the grocery store, you go to the mall, you have to know where every bathroom is. You have to take pads, supplies. You get yeast infections. You get irritation of your skin because you're wet all the time. You can get frequent urinary tract infections. So it's an added expense because you're always buying pads and liners and etc. And it's also an emotional impact on a person's health. So what can we do to treat stress incontinence? Now, these treatments can apply really to both men and women. The first line of treatment would be pelvic floor exercises. We'll talk about that in a bit. The second option is urethral bulking agents. We've had them around for a very long time, and most of the bulking agents in the past did not work well, but in the past few years we've been offered a newer agent that seems to have a lot of promise in long-term treatment of stress incontinence. The third option, which has been around for a long time, over 30 years, is the sling surgery, and there's various ways of doing a sling surgery, but it has been the time-tested gold standard, but at the same time it is a surgery with risks associated with an operation. So pelvic floor exercises, really hard to do on your own. We don't know what muscles we're working on and how to make those muscles stronger. So one thing you can do on your own is practice stopping your stream when you're urinating. In women, you can also put a tampon in the vagina and practice squeezing on that, usually for a count of 10, relax for a count of 10. Well, obviously take the tampon off after you're done. The other thing you can do is quick flicks. That's where you know you're going to get up to urinate and you're going to end up having leakage. So you sit down and you do 5 quick flicks where you tighten those muscles 5 times and relax them. That kind of subdues the urge so you can get up and go and hopefully not have leakage. But you can also go for physical therapy. The therapists work with the patients. There's quite a few of them now that specialize in pelvic floor health, and they help you do these exercises through computer-generated programs. There's also something called electrical stimulation, which is to help, so to say, wake up the pelvic floor muscles when you go for treatment. The problem with pelvic floor therapy or going to a physical therapist is that it's time-consuming, and you have to go in multiple times, sometimes 3 times a week, and you have to, have a ride or be able to drive there. And a lot of the patients that have this problem either don't have the leisure to go 3 days a week because they're working, or they're older and they don't have a ride. So other options would be, one would be the sling surgery. Obviously the person has to be medically okay for surgery, but the goal is to re-support the urethra. It truly is like a sling, a hammock for the urethra. It is an outpatient surgery. We use a small piece of mesh to wrap around the urethra through the vagina. You go home the same day. The main risks really are the risks associated with mesh. The FDA did issue a warning on the use of mesh for pelvic floor repair. It has been banned. However, for slings, it is acceptable. It's been the time-tested standard. And with that said, people are more nervous about getting mesh in their vagina. It can contract. It can cause urinary symptoms that you didn't have before surgery. It can cause urgency-related symptoms sometimes because if the mesh is too tight, the person has to urinate frequently. It can cause difficulty urinating at some times, so these are things to consider. The sling is also an option for men with incontinence after a prostatectomy. The outcomes in men are not exactly as good as women with the sling, but it is an option. The next option, which has been around for a long time, is a urethral bulking agent. In the past, and I've been in practice now for 22 years, didn't really like them, I'll be honest. I mean, they didn't last long, or whatever you put in leaked out, and the mechanism of delivery was terrible, and didn't really like it, and it was one of those things that you reserve for people that failed everything else. But in the past few years, a new bulking agent has been available that can be placed in the office. It's injected directly into the urethra to create little pillows that close it off so that when a person coughs, sneezes, laughs, urine doesn't dribble out. And we have follow-up 6 to 7 years now, and it still lasts. So it's not something you need to keep coming in for over and over again to get re-injected. Where the old bulking agents, that was the case. They would wear off or they would leak out, and then you had to get another injection. With this agent, usually we do the injection, and then at 3 months, if the person still has some leakage that's bothersome, we can do a second injection. But it's not something they should be coming back for every 3 months to yearly. Once it's done, it's done. The main side effects are little burning with urination, little blood in the urine. Occasionally, after the procedure, the person may have difficulty urinating, which is also the case with the sling. But with this, you can usually put a small catheter in to drain the bladder, and then by the next day, this problem is resolved. Whereas with a sling, it's a much more difficult process to try to fix the problem with difficulty urinating. So how does the bulking agent work? And we kind of talked about that. You do it in the office. In men, it's not FDA approved, but I have seen some good results in men as well. We do it in the operating room for men. But in women, we can give some local anesthetic and pass a telescope into the urethra and basically inject this agent. This agent is non-biologic. It's basically a matrix, and it's been used in South Korea for facial fillers, and that's how we learned about it and why we found that it's very effective for urethral bulking. It's very safe, and once it's in, it doesn't leak out like the other agents do, but sometimes creates a bubble or a pillow that can pop, and that's why a second injection may be necessary. The majority of people have both types of leakage, stress incontinence and urge incontinence. So you can have leakage when you have a strong urge to run to the washroom, and you can have leakage when you cough, sneeze, or laugh at the same time. You can get urinary tract infections, you can get yeast infections from persistent moisture, you can get skin irritation, wound breakdown. There's a lot of treatments for urge incontinence. Many different types of medications. We try to find one that suits you. And then if medications fail, there's Botox as an option. And if Botox fails, there's also a pacemaker for the bladder that we can do. We always try to get prior authorization from the insurance before any procedure. Whether you have a deductible or some copay that you have to pay on your own is between the patient and the insurance plan. Thank you for watching today's webinar. If this is a problem that affects you, please call and make an appointment.